Hey, it's Jeremy Faust, editor-in-chief of MedPage Today. We're going to dive into Season 2, Episode 1 of The Pit, my reactions as a practicing ER doc. Let's take a look.
Did you not get a packet from Dr. Underwood, Gloria? It outlined the quality improvement changes I instituted at the VA. We're adopting the program at all of the university hospitals. You didn't read it?
No, I did. I will. I'm going to. I want to. I thought I had a little bit more time before you came in today.
We've already distributed patient passports to everyone at registration.
What is a patient passport?
So glad you asked. Samira.
Dr. Al.
We worked together at the VA a few years ago, and now you're in R4.
Yes, and I'm so excited you're joining us. Dr. Mel King is here too. I think you worked with her as well.
I did indeed.
All right, there's like so much going on here, and I just love it. The first thing is this idea of this patient passport. They're going to give everyone packets, the patients, so they know what to expect and what's going to come next. And this is just a classic idea of someone trying to make the ER better. And ultimately, these things, I hate to say it, just never work, because ultimately you're rearranging deck chairs, and they have this notion of some rolling out some idea, and it's just really hard because no 2 days are alike. It's just, there's no way to standardize this. And really what she's reacting to is of this idea that patients don't feel like they know what's going to happen next, and that is unfortunately just inherent to emergency care. The other thing that I think you saw was Dr. Robbie sort of trying to be nice, but rolling his eyes with this, because probably Dr. Robbie, he knows this story, that someone comes in with an idea and they really mean well, but is it going to work? Probably not. And the thing I will say is that the Pit, as I've seen it, is very much doing this thing where it's taking something very real, this could happen, and kind of compressing it.
What the hell is it?
Patient passport. Lets patients know what they're waiting for and how long it'll take.
When do we start this?
Today, the new attending.
It's just a great example of people meaning to do well, but it's just really hard. How do we make life in ERs better? Resources. More doctors, more nurses, more techs, more beds, more space, more room on the floor in the hospital so that when they get admitted, they're not waiting in the ER for 15 hours at a time or longer. And so I get where she's coming from, and I get where he's coming from. Okay, so next let's get into our first clinical situation, and this is the vignette of a young child who they're beginning to suspect has had too many injuries for it to be ignored. Like, what's going on? Why does this kid have more injuries than just the one that they initially showed up with? Let's watch the clip.
Okay, big breath. All right, lungs sound great. Can you lean forward for me? Did you hit your back when you fell down the stairs?
No.
Okay, there's a pretty good bruise here.
I got knocked down in soccer.
Oh no, you broke your wrist last year too, huh?
Fell with my skateboard. Got a purple cast.
Cool color.
And you were treated at West Penn? Is that your closest hospital?
I guess that would make sense. I've only been dating her dad a few months. He lived in Garfield before the divorce.
And what about these?
Soccer.
Do you wear shin guards?
My dad ordered them.
What does your dad do for work?
He draws buildings, but he's not an architect.
He's a draftsman for a firm in Newcastle.
Kylie, any chance you can pee?
Maybe.
Okay. Well, with the bruise on your back, we need to check your urine.
Okay.
All right, so there's a lot going on here. First of all, The Pit is a very sophisticated medical show. It is a different level from a lot of the shows that have been on in the past. So my suspicion here is that this is going to end up being, they're going to go down the road of what's called non-accidental trauma, which you might just call abuse, right? There's some issue that's non-medical that we're supposed to kind of be clued into because of these different bruises that are a little unexpected and a previous injury, like the wrist being broken. And so when we're looking into things related to non-accidental trauma or abuse, we are looking for a pattern of multiple injuries over time. So it's like, okay, lightning can strike, but why does lightning keep striking the same kid over and over again? And then the concern is that it's being done to them. But what's so complicated is that even that stuff is not definitive. And it's very scary for the parents, because if a kid has an injury on an x-ray that sort of reminds the clinician of something on the abuse spectrum, then all of a sudden there's case managers and social work and child protective services in there, and all that might be appropriate, and yet it's still very possible that that injury had nothing to do with abuse or neglect. So what I'm wondering here is, just because the Pitt is such a sophisticated show written by doctors or with doctors at all times, whether they're going to go beyond this and say this child has some kind of connective tissue disorder or a bleeding disorder that explains these injuries other than abuse. So this is one of these situations where I'm curious as a viewer, are they going there? Are they going to the beyond the abuse, beyond the medical explanation? And it could be both. And so that's what I think is so interesting, not just from a dramatic perspective of this show, but just the viewer getting a chance to see what it is that we confront as clinicians. And the reality is it's not always so clear cut. And so sometimes you can have these things on a spectrum that are overlapping. And that's when I watched these scenes, that's what I was thinking. I was thinking, where are they headed with this? And just how close to realism is this? And I think that reality is messier. Whereas I think old medical dramas and textbooks would make it clean. It's either going to be abuse or it's going to be a medical explanation. Could be both. Okay, lastly, we're going to go into the most graphic scenes that you're going to see in any medical drama. This is the traumatic arrest. A patient comes in who died due to a trauma, and therefore in the ER, it's indicated to do what's called a thoracotomy, to open the chest and to expose the heart and lungs to see if you can find the source of bleeding and to stop it. And that's a temporary measure to get that patient to the OR to have that injury repaired. And if you can save a few lives here and there, it's worth the many times when you fail and the patient dies right there, or they die in the OR. And so let's just watch this. It is extremely graphic and quite realistic anatomically, so fair warning.
Can't locate the source. Proximal hilum is under the sternum, along with most of the right ventricle.
You need better exposure.
Convert to a clamshell.
Exactly.
Trauma shears.
Might have been nice to let them come up with that plan.
Heart's gonna need double compressions, just like this.
Squeeze from the apex to the aorta.
Right ventricle looks good. Massive hemorrhage from the hilum.
Second MTP packs going. Additional 4 units.
Hilar injury looks very proximal, maybe pulmonary artery and vein. Clamps on. Nope, no good. Still bleeding like a stuck pig.
I can give it a
Dr.
try.
Garcia is a very skilled surgeon. If she can't get it, we need to think of something else.
Like what?
Hilar flip. You're gonna rotate the lung 180 degrees, like putting a kink in the garden hose. It'll stop the bleeding.
That could possibly work.
Or he'll die when you rip the entire lung off the hilum.
Gently. Very gently, very slowly.
Blood loss is slowing down.
That's a good sign.
Hilum looks dry.
Maybe the heart feels empty.
Okay, we fixed the leak. Now let's fill the tank.
Okay, so much going on here. Fantastic anatomical representation of a thoracotomy. Really appreciate that. But I thought it was interesting just to hear the conversation about Robbie saying, hey, let them figure this out, right? Rather than giving them the answers. This is the classic dilemma in a teaching hospital, which is give the residents and students a few seconds to figure out the answer themselves, rather than just saying, here's what you should do. Because a lot of medicine is not just the technical aspects, it is the cognitive aspects, and giving them a chance to think of the next step is the better way, as long as you're not threatening the patient's life. A couple seconds here won't make a difference. I think he's right to let them think about it. The next thing is this notion of what they're trying to do is they're trying to clamp, and it's not working. And here they've got this idea that the bleeding is coming from the hilum, which is like the sort of really like central part of the lung, the vasculature that goes into really from the heart going over to the lung. And basically the idea is that if that's where the bleeding is coming from, and it's coming from really close to the heart, proximal, that the only way you're going to fix this is, as Dr. Robbie says, like, quote, kink the garden hose, to sort of twist things around. This is called a pulmonary twist or a hilar lung flip. So that's what this is. That's what this is dramatizing. as many things in this show, everything is compressed in time, so that they show the flipping of that lung.
Hylam looks dry.
A little bit of dramatization here of everything working a little more quickly in the show than it would in real life. They decide very quickly, oh wow, that worked, that was great. And then he invokes this idea of, okay, now the heart is empty, meaning there's no blood. This patient has basically lost more blood than they can possibly reinfuse. So Robbie says, okay, well, we've got the pipes figured out. Now let's put some blood back in this tank. And that's the idea of just continuing the massive transfusion protocol. But then we get this next thing, which is really fun to watch because it's, again, fairly accurate. We'll take a look at this next clip in which they take a look at the heart and they see what needs to happen. And they do it. Let's take a look.
Hardly any hemorrhage on the right.
Looks like the flip worked.
How's the heart, Whitaker?
Feels full of blood. First time since we started.
Hold compressions.
Quivering bag of worms.
Resume compressions.
When the heart quivers like that, it's obvious VFib.
All right, so I'll just say that that's very accurate. That is, the VFib is ventricular fibrillation. That is a heart rhythm that is not compatible with life. The heart is not compressing blood in an organized fashion, so the blood just can't really be pumped out. And so VFib can never be sustainable with life. And so they're going to have to do something about that.
Okay, internal paddles ready?
Charge 2.
25
50 joules.
So some debate about how many joules to deliver to the heart. Yep, some people say more is better. Some people say, no, you can actually hurt and scar the heart by giving too much electricity, so do the least possible. But whatever, either one is fine.
50 gets it right the first time.
Charge.
Okay, Whitaker, when you're ready.
Clear.
That's what normal sinus looks like.
Very cool that they show that so accurately. Indeed, that is what happens. A lot of times in this show, they compress things, and things that take minutes take seconds, or things that take hours take minutes. In this case, when you defibrillate in a chest like that, you will literally see what we just saw, which is a heart go from nothing organized to this very organized kind of heart contractions that look normal. And of course, Dr. Al is happy to see it.
Strong carotid. Saline lap pads and up to the OR.
So they're saying, let's get some basically some gauze in there to like clean up the hemorrhage and get this patient upstairs. Again, all these things happening very quickly. It'd probably take a little longer for everyone to decide what to do next, but more or less that's what we'd see. Okay, that is just a little bit of a 10,000-foot view on how I see these scenes. Could probably spend an hour on these, but you get a little bit of a sense of what it is that we do. And I really just admire the creators of the show for making it this literal and this well done. So if you want to see more, join us next time. We'll do another episode. All right, thanks so much for watching.